But what's important to understand about the reproduction number is if it's even slightly above 1.01, everyone gets it eventually. It just takes a long time, right? That means it takes 100 people to cause 101 people to become infected. Okay, well, you'll still end up infecting everyone. It just takes a very long time, so it's easy to control. If we can dip it below 1, and this is where we talk about in terms of controlling a pandemic, you don't have to catch every case. You don't have to isolate everyone who gets sick. You just have to catch the bulk of them, because you can get far below 1, which means on average, every person who gets it is going to infect less than one other person. It's like the birth rate, right? If a couple has less than 2 kids, then if you think about it over generations, the population is going to get smaller. So same thing with COVID. If you can just get that reproduction number just this much under 1, eventually it peters out. And so that's been the goal. It's not been to catch every case. It's to push the reproduction number down. And the best way to do that with COVID, obviously, because of super spreader events, is to go for those large gatherings. That's the thing.
So you're a Canadian infection control epidemiologist. That's the official title?
That's what I am on Twitter.
Yeah.
So yes, I am. So let me clarify that, because my background is a little bit complicated. I am an infection control epidemiologist by training. I studied at the University of Toronto to do that. I also have a PhD from the University of Toronto. It's not in epidemiology. It's actually in knowledge management, how knowledge gets created and used by individuals and organizations to aid in decision making and getting smarter. So my interests lie actually right at the intersection of what information and knowledge are, and what makes for valid knowledge and information, the use of tools and technology, and public health and epidemiology. So people like to know sometimes who pays my salary. I'm an assistant professor at the Faculty of Information at the University of Toronto. I have what's called a status cross appointment to the School of Public Health, which means I get involved there. And I didn't really call myself an epidemiologist much before COVID started for the last couple of years, because it hasn't been a main focus. So in a sense, I've kind of dusted off that credential. And to the extent that I talk to media, I think it's because I'm able to connect a social science background with a biomedical background. So it gives me a critical lens. But I don't want people to think I have magic I don't have.
I don't think there was a faculty of information when I grew up in Toronto at U of T. Is this data science or?
Well, we have data science now. Actually, you just nailed our newest concentration. It was the library school. So it began life as a library school. And if you think about it, information used to live in libraries, right? And then it started to seep out and pervade the world. So we started to expand the way we look at the world. And libraries are only simply a small part of what we now study and do.
Okay. Well, I guess that brings me to my first question, and a very common kind of objection to the pandemic and objection to any kind of vaccination program. And that goes something along the lines of, how do I, as a citizen, know that Mr. Pfizer isn't lying to me about the efficacy of his vaccine? How do I know that he's not in league with Mr. Moderna and Mr. World Health Organization and the CDC and Dr. Fauci and the Public Health Authority of Albania or some other EU country and New Zealand? How do I know that this is actual information, that this isn't just Pfizer or whoever feeding us a line of BS about the efficacy of the vaccines?
Well, it would take a remarkably large conspiracy involving thousands and thousands of people. And in such a polarized day and age, trying to imagine getting 10 people off the street to agree on anything seems pretty unlikely, let alone thousands upon thousands. So when drugs are developed, there's a lot of eyes on them, right? There's regulatory eyes, there's independent monitoring committees that are drawn from competitors, that are drawn from industry, that are drawn from university scientists who are not in people's pockets. So you've got, by the time you get to a clinical trial, which needs to be registered, right, with the US government, you can see who's involved, you can see all those sorts of things. You've got a steering committee, you've got a compliance committee, you've got an audit committee, you've got an ethics committee, you've got so many different people, and they will have disclosed what stocks they hold and what their various different motivations are. So it would be pretty hard to imagine how you would either hoodwink or ensnare in some conspiracy this wide range of people. Then you have to think about the study participants, right? So let's say the vaccine doesn't work and there's a conspiracy to say that it does. So you're going to have study participants showing up in hospital with COVID, feeling really sick. Now, how do you persuade them to not talk about the fact that they're in a clinical trial? And if they do talk about being in a clinical trial, now you're going to have to persuade lots of people at the hospital to hush that up. When you're talking about tens of thousands of participants in a clinical trial, the odds of that happening are very small. And let's assume, I mean, if you're assuming a conspiracy, I guess you're assuming that there's control and greed and fame and fortune at stake here. Okay, what better way to achieve fame and fortune than whistleblowing on a conspiracy? So you've got a pretty potent, I think, motivator for just one person in these thousands and thousands of people who are involved to actually be able to shine a light on a bad thing. So it's just remarkably improbable that you could ever pull that off at any time in history, let alone today when people are just so polarized.
So I think a lot of people who don't know this kind of assume that, say, Pfizer, they'll accept that Pfizer and Israel struck a deal and basically will inoculate your whole country if we get access to the whole data set. But you're saying that there were actually independent people keeping an eye on the data as it was coming in. It doesn't go from the I don't know, directly to Pfizer, and then Pfizer decides what to give out who to give out that information to and cook it
That
first.
is correct. Every country has a health authority. In Canada, it's called Health Canada. In the United States, there's the FDA. They monitor these things. And no drug gets used in the country without those organizations having a close look at data and access to the people involved. So, again, every time you try and take something out of a lab and put it into people's arms, you're involving thousands upon thousands of people with different interests, with different motivations, and trying to line them all up for a conspiracy. It just doesn't make sense.
Yeah, well, there's that old mafia saying that two people can keep a secret if one of them is dead. And trying to, being a captain at a fire hall and trying to have seven guys or five guys trying to do the same thing, that's hard enough. And, we're just going to keep this as a
Yeah,
secret within the hall. It never works.
right.
It's like, um, okay. So what about kind of the information around, because we've got the vaccine and we've got known small risks that are coming in from public health agencies and drug companies like Pfizer. But at the other hand, we have to judge those risks against the risks of the actual COVID infection, and that brings us to some, I guess, central uh, arguments. Right, the survival rate of this thing is 99.9998%. Well, hang on. Do you know how to convert a decimal to a percentage? It looks like you don't. How do we get a good handle and trust the numbers on the infection fatality rate, the case fatality rate, the percentage of people who don't die but turn into long haulers? I mean, here there is more kind of, it would appear to the public, whistleblowing, because you do have doctors saying the risk from this is way overblown. In my understanding, they're a tiny, tiny minority, and it's like 99% of people kind of agree. But how do we navigate those numbers and maybe define those numbers for us, because they're so central to a risk
They are,
assessment?
and so that's a pretty complicated landscape. And in any kind of situation we're in right now with a new drug that is generating data as it's being injected into people, and there's measurement going on, and yes, of course, side effects are monitored. You're going to have in the scientific community people who are outliers, people who are outspoken, people who are iconoclasts, that they disagree, and they're going to push their own version of events. Again, that makes it so hard to have a conspiracy, right? You can't. No one can seem to agree on one set of facts, and that's the one thing that you need for a conspiracy. So COVID is an interesting monster because it presents asymptomatically and mildly in a majority of people, and we don't even know the size of that majority. That would be a really hard thing to measure, and countries tend not to have measured it. You would need to be going out and doing random sampling in the population a lot, constantly, and that's been done in snippets here and there. But if you don't know how many people are catching the disease at all, then it becomes really hard to do things like figure out what proportion die from it, right? Or what the symptomology is like. So there's two numbers you mentioned: the infection fatality rate and the case fatality rate. The case fatality rate is of all the people who have been formally diagnosed, right? They've been tested. It's like, you have COVID. All right, so now you're in that group. You're a case. What proportion of cases die? And that number has varied from something like 0.5% to 11%. And it really depends on the where and the when. If you are in a situation like Brazil or Northern Italy at a certain time or New York City at a certain time, when a healthcare system gets overwhelmed, people die. They die a lot. And they also die from things besides COVID. They have heart attacks and they're too afraid to go to the hospital. So you have a lot of death around that. Where you have a lower amount of COVID where the health system can cope, we've learned a lot about how to treat it. Just blood thinners alone to stop blood clotting, just that alone has saved a whole lot of lives that we weren't saving throughout the spring and summer of 2020. So just trying to pin down how many people does it kill? It depends when, it depends where, and it depends on what's going on with the healthcare system. And there's also probably genetics in there. And certainly there's no question in my mind that there's differing population immunity depending on where you go. So that's just with the cases that we know about. But again, you can have this idea that maybe thousands, millions, billions got it, but in such a mild form that it just didn't matter to them. So that's when we talk about the infection fatality rate. So if we try and estimate globally, how many people do we think actually had this? And then we divide the number of deaths by that really big number, then COVID starts to look like flu. Right? Then you start to get something like a 0.1% fatality rate. And so a lot of people out there who are saying, oh, COVID is really just like flu. Well, you're using this gigantic denominator based on a guess of people who maybe technically had this, but didn't. And so is that an important number? See, I would say that flu doesn't overwhelm healthcare systems like they do now, like what's going on now. It's ludicrous if you look at how COVID has swept through urban areas to compare it to flu, right?
You're in
So
Ontario, and Ontario's like basically in a shutdown, and the Ontario healthcare system
yeah,
is pretty much
we're
overwhelmed,
about
and
to
they're
start
setting up.
pulling up refrigerator trucks outside hospitals. Influenza doesn't do that. So what that says to me is if you're using the infection fatality rate to say COVID's no big deal, COVID's just flu, you're ignoring the reality, like the clinical reality, right? That our healthcare systems are being overwhelmed. Now they're being overwhelmed by hundreds and hundreds of people who are seriously ill, not millions, but hundreds. That may not seem like a lot, but it's enough to cripple a healthcare system. It's not what we're used to. It's far more virulent than other things that we see. And that tells me that using, an infection fatality rate with an estimated gigantic number of people who you think may have had COVID, this isn't helpful. It isn't actually describing what's going on. Using those numbers to make COVID seem like flu is just ignoring reality. So I think it's good to start with reality. It's good to start with what's going on in hospital. Why are so many people on ventilators? Let's characterize the disease that way. And then let's go wider from there and say, okay, from all these very ill people, many of whom do not ever come off the ventilator, right? Your odds of surviving are kind of 50-50 once that happens to you. When you're trying to consider, well, what happens to people who aren't quite that ill? Now, how about not quite that ill? Where can we draw a reasonable line between what we should consider a case? It's complicated, right? And COVID also manifests in a lot of different ways. It gives you diarrhea. It causes severe stroke. It does everything in between, right? So it's pretty complicated disease. And part of that is because the virus itself has what we call the spike protein that you may have heard a lot about. It's got a very clever spike. The great metaphor I can think of is, which a lot of people use, is a lock and key. So your cells, your body cells, have locks all over their surface, right? They're fortresses, but they're supposed to let certain things in and let certain things out. So COVID comes in with a master key, a skeleton key, and it's able to pop open cells in your body who go, oh, you got the key, sure, come on in. Well, it's got a pretty darn flexible key. So that key can open cells in your throat, in your lungs, in your heart, in your kidneys, and the inside of your blood vessels, arteries, and veins. All over your viscera, this key works. And so it can attach itself and manifest in all kinds of different ways. And that leads me to another point, is that when we just talk about fatality, when we just talk about who's dying, that is the obvious and probably most important measure of disease, but it's not the only one. Long haul COVID, which we're still only just starting to understand, looks like it's an autoimmune problem, right? Like multiple sclerosis or lupus, where the body's antibodies get a little bit confused. So they show up to the scene where the virus is wreaking havoc, and there's virus parts all over the place, and there's parts of your exploded cells all over the place, the antibodies lock onto part of you instead of part of the virus, and they start imprinting on that. That's probably what's going on. That seems to be what's going on for at least some, if not many, people in long haul. Brain damage is another. People who subsist in a fog of sorts. This is very similar to what happens to people sometimes when they have traumatic head injuries, right? That the brain has suffered significant damage, and often brains are pretty elastic. They recover better than you might think for most people, but it's a long, nasty process. And I don't want a head injury. I don't want a traumatizing head injury, and I don't want COVID, because they can lead to the same thing. Even assuming I survive both, they're both something that you really don't want to have.
Dr. Chris Moriarty, who's in the States, who I've done a fair number of episodes with, of talking about COVID in the context of Brazilian Jiu-Jitsu, has mentioned that it really looked like him to, like, like a chronic head injury that for many of the long haulers, it was looked like they had some kind of traumatic brain injury. And you're also in lockstep with another guest who's been on the show, Dr. Nicholas Tayau, who was talking about one of the most useful indicators, hospitalization rates, because case rates, how much are you testing, who's going to get tested, are you not getting tested for ideological reasons?
Sure.
But once you start turning blue and you can't breathe, you go to the hospital. So you can't fake that.
That's a really good point, that the criteria for admission to an ICU, you've got a stable population, you've got a stable healthcare system. Those are kept constant. So when ICU admissions go up, that's a yardstick no one can quibble with. You've got absolute certainty. You can count the number of people who have been forced to be put on ventilators, and they are all diagnosed and rated and treated according to very similar yardsticks. So yes, I think that's an excellent point.
Okay. Can you talk a little bit and take us through, I don't know, epidemiology 101 or 10.5, and just talk about the concept of herd immunity and how this relates to vaccination rates, the number of people in the population who've had an illness, and the R naught value, the value of how many people one person infects when they have an illness. I guess it could apply to everything from measles to smallpox to COVID.
Yeah, well, so yeah, let's start with that. Let's start about the R naught, or the basic reproduction number. So in a vacuum, not thinking about context at all, let's just hold up COVID as a species of virus, right? So there's COVID. It's got properties. It's got the spike. It's got DNA in it that tell it what to do and how to reproduce, and it behaves in a certain way. And when you release that into a person, it does certain things to them, right? And in some cases it's mild, in some cases it's not. But one thing we're particularly interested in is, once one person gets infected, how easy is it for that person to then go and infect other people? And that is the reproduction number. So the reproduction number is a measure, isn't just an estimate, it's kind of a hypothetical number. It's an estimate of, for every new case of COVID, how many additional cases will that case directly cause? So a virus that kills you very quickly. Let's imagine that there's a virus that kills you in minutes. It's not going to be a very successful virus, because you're going to die before you can infect other people. Okay. But if we look at a virus like measles, measles doesn't kill most people, but it's really good at getting out of your body and floating in the air, right? So the reproductive number for measles, which is the most contagious virus we know, is about somewhere between 15 and 18. That's why we get really worried about measles outbreaks. The reproductive number for influenza is just a little bit above 1 point something, and it depends on the season. Depends on the specific flu. For COVID, it's somewhere between 2 and 4. We could just call it 3. But the idea of R naught, like that R0, says essentially we're doing this estimate in one particular condition, a condition where the virus is new, it's novel, there's no population immunity, and there's no interventions being done. So no one's wearing a mask, no one's being shut up. We're just going on our lives. We're just going to ignore it, right? We're just going to ignore this new virus. Then the reproduction number would be something like 3 or 4. Now that may not sound very high, but 3 or 4 means the entire population gets it pretty soon. Okay, so
it's a little bit like that whole, I'll give you 1 grain of rice today, 2 grains of rice tomorrow, 4 the next day. It still doesn't seem like much, but by day 20, you're giving, I don't know, the entire production of rice throughout human history to somebody.
The way I learned it was the king decides to give you a reward for some good deed, and you simply say, well, for 30 days, I want 1 penny the first day, and then 2 pennies the second day, and then 4 pennies. Well, it bankrupts the king, and it does it all in those last few days, right? The first week or two are pretty cheap, and it gets pretty quick from there. So that's the reproduction number, the what we call the basic reproduction number. But there really is some population immunity, and we really are doing certain things like wearing masks and being socially distanced. And so then we're interested in a different kind of reproduction number, not the basic reproduction number, but what's called the effective reproduction number. So given a real context now, a population that's got some immunity, and let's be clear, there is population immunity to COVID, just not as much as we need. Given that we're doing certain things, given that maybe, like say in Sweden, everyone lives on their own, and in northern Italy, everyone lives in multi-generational housing, right? That doesn't change the properties of the virus, but it changes the effective reproduction number, how we choose to live, and how poor we are, and how malnourished we are, how old we are, all those sorts of things. It doesn't change the virus, but it changes the impact that the virus has in a population. So the effective reproduction number is essentially that number of how many new cases will you cause if you get infected, given the context that you're in.
So, if you were working as a public health epidemiologist and your job was to figure out the effective reproduction number in Toronto, where you live, or in Scarborough, which is part of Toronto, or how would you go about doing that? Like, what would you do on day one? What would you do on day two? Because these numbers seem all airy fairy and pulled out of the air, but obviously they're coming from data.
They're estimates. They're estimates, and they're kind of hypothetical. And let me go
Okay.
back to this idea of hypothetical for a moment. What we know about COVID is most people who get it don't give it to anybody at all. But some people who get it give it to dozens and dozens in super spreader events. So it's not evenly distributed. So the idea of this reproduction number, again, it's an average. It's very hypothetical. It doesn't tell you really what actually happens to people. And what we do is there's a mathematical formula to estimate it. And again, it's not a measurement, it's an estimation. And you look at case reports day by day with an estimate of the inoculation period or incubation period. How long does it take from exposure to being infected? And so there's a formula that relates those two things together. How are cases increasing from one day to the next? And how long does it take from being exposed to being contagious, to being infected, to being not contagious anymore? And so we're seeing estimates around somewhere between, sometimes very close to 1.1, one less than that, and going all the way up to in certainly in Ontario, it's spiked all the way up to 1.3 or 1.4. Again, that doesn't seem like a very high number, but what's important to understand about the reproduction number is if it's even slightly above 1.01, everyone gets it eventually. It just takes a long time, right? That means it takes 100 people to cause 101 people to become infected. Okay, well, you'll still end up infecting everyone. It just takes a very long time, so it's easy to control. If we can dip it below 1, and this is where we talk about in terms of controlling a pandemic, you don't have to catch every case. You don't have to isolate everyone who gets sick. You just have to catch the bulk of them, because you can get far below 1, which means on average, every person who gets it is going to infect less than one other person. It's like the birth rate, right? If a couple has less than 2 kids, then if you think about it over generations, the population is going to get smaller. So same thing with COVID. If you can just get that reproduction number just this much under 1, eventually it peters out. And so that's been the goal. It's not been to catch every case. It's to push the reproduction number down. And the best way to do that with COVID, obviously, because of super spreader events, is to go for those large gatherings. That's the thing that pushes it further down. Because ultimately, in a lot of ways, we could say that COVID is actually not that contagious. It's not measles. It's not even anything close to measles. And so it ought to be controllable. The fact that it hasn't been in so many places speaks to, I think, mismanagement, horrible mismanagement, not being proactive. Treating COVID like a political opponent as opposed to a disease, for example, trying to negotiate with it, trying to come up with a good news message for people. Those kinds of approaches don't work. So even with a reproduction number that's only a little bit above 1, those kinds of failing approaches simply cause more COVID. As long as it's above 1, you get more of it and not less of it. So that's a little bit depressing for people who understand communicable disease dynamics. This is avoidable. All of this that we're
Are
dealing
you
with
saying that
COVID.
we need to go to what's called lockdown, which is pretty variable in what it's defined as, but do we need to go to a lockdown to get it below 1?
Well, lockdowns are easy to understand, right? If you can just isolate absolutely everybody, then the virus isn't giving an opportunity to jump. And so this has been a go-to. Politicians understand lockdowns, right? You don't need to be a scientist to understand that. It's very easy to understand, but it's not the only way. It's the only way when you don't do anything else. When you take no other measures, that's all you got left in your toolkit. And that has characterized a lot of regions, including Ontario, where I am. But it's not the only way. Rapid testing, or just mass testing, right? That's another way. Instead of locking people up and waiting for the disease to stop spreading, you go find cases. You go out and find them. If there's 40 million people in Canada, all we need to do is conduct something like 20, 30 billion tests a day, and which sounds like a lot, but it isn't really. Not if you scale up for that. We all brush our teeth that many times a day, right? Or twice that many times a day. So it's not that hard to do. If you do that, you may not catch every case every single time, but again, you don't need to. So in other words, we could have managed this through testing. Slovakia tested the entire country, found a ton of undiagnosed cases, isolated them, and their case counts crashed. Then they stopped. Cases came back up, right? Probably mostly because of travel. Liverpool just decided to come out of, in the UK, decided to come out of lockdown and do rapid testing instead as a big experiment. It worked pretty well for a while. They made two mistakes. They used poor quality tests, so they weren't catching as many cases as they ought to. And they also, they had government scientists wearing lab coats who looked kind of intimidating. And if you're someone who maybe is undocumented, or maybe you got a pass, maybe you got something to hide, maybe you come from a culture or a background where you just don't trust government, right? Like there's a lot of reasons not to trust government, right? So if you're like that, you're not coming forward to get tested, right? And those folks, those marginalized people, marginalized, often racialized, often excluded, those are the ones who are actually most at risk for COVID. So Liverpool had partial success. Denmark is now testing 8% of its population every single day.
Really?
Good for Denmark. Yeah,
Wow.
they're going to bring COVID to its knees. So when we say, do we have to do lockdowns? No, lockdowns are something politicians understand. Lockdowns are something that politicians impose. And lockdowns are something that epidemiologists support when we have decided not to do anything else.
Okay. What about the sort of intermediate measures like mask wearing and, banning gatherings more than 10, what most of Canada is doing right now, like no meeting of people, groups bigger than 10, try to meet people outside, mask wearing, assuming people actually did that, because I think the recent, like Whistler, the world famous ski resort, got shut down here. I believe I heard rumors that the case positivity rate, meaning the percentage of people who got tested who showed positive, was something like 50%. I have not been able to verify that, but that was the rumor I heard.
Yeah.
So I don't think those measures are being followed there, but would that be enough to bring it under one? Like less draconian measures and not testing?
So you're asking a very hypothetical question, because what you're saying is if everyone were compliant. And the answer, I believe, is probably yes. We don't know. And I want to be clear, we don't know because we've never been in a situation where everybody is being compliant. Everyone's got their way of interpreting the rules. Everyone's got a way of coping, of making this thing sustainable. And I've seen it left, right, and center saying, well, I'm very careful, but obviously not with my buddy because, he's my buddy. So there's, just quite a lot of that. And again, COVID spreading asymptomatically means that when you start to negotiate, when you start to bargain, when you start to find ways to adapt the rules to be less inconvenient, you're giving COVID a really big opening. But what we find, among staff who work at a resort, they hang out together. They're sharing cigarettes and joints. They're in the staff break room. They're taking their masks off, right? Who likes wearing a mask? Really, no one likes wearing a mask. Really, no one does, right? So if there are opportunities to not wear the mask, well, then that happens. And we see that in big box stores too. You don't have to have an environment as big as Whistler. The staff who work there, they hang out together, right? That's what they do. And no one's looking. And the masks come off for the smoke breaks because you can't smoke through a mask. And then this sort of thing happens. So you're asked the hypothetical question you're asking, which is if all we did was ban large gatherings and have everyone wear masks when they need to, that would probably be enough to make it go away. Yes, it probably would.
All right. Well, I like how you couch that as probably and we don't know, because as opposed to saying this is the answer.
Well, anyone who says this is the answer for something like this is probably trying to sell you something. I think we need to be somewhat humble in terms of what we
most typically. So can we move? So I think you did a really good job of explaining the R naught and the reproduction number.
Herd immunity we didn't get to though. Do you want to talk about herd immunity?
Because herd immunity is being touted by people who, until like 2 months ago, didn't know well, probably still don't know the definition of a virus, but they're more than happy to wave the term herd immunity around.
Yeah.
What is herd immunity? What goes into it? And have we examples of this occurring naturally?
We use the term herd immunity, and we never used it before we had vaccines. So we use the term herd immunity to talk about what do we accomplish with vaccination. And I think it's really important for people to understand when you get vaccinated for something, it's not to make you immune. That's not how vaccination works, really. It does create an immune response in your body. But if you go into a room absolutely packed full of virus, you're still likely going to get sick, possibly very sick, right? So it's not like all of a sudden you're Superman. What you're doing is you're equipping yourself, you're equipping your immune system, you're giving it essentially instructions or a picture, an image of what the bad guy looks like. Okay, so that's what it's doing. And again, if there's virus circulating everywhere, you're still likely to get sick. And of course, we have seen news reports now of people who said, "I had both my Pfizer shots, and here I am in hospital sick with COVID." Well, you shouldn't have taken the mask off and gone into a big crowded room full of people with COVID. Is the answer, because that's not how vaccines work. Vaccines work by once you immunize enough people, and you don't have to get everybody, but once you get enough people, the virus has nowhere to go. In other words, it's so much less likely to spread, and it peters out, it disappears. It's like a door-to-door salesperson trying to sell can openers in a neighborhood where everyone's already got a can opener, right? He's not making any sales, right? So that's what you try and do. You try and get rid of COVID. You make it stop circulating. So it's the power of the herd, not the individual, that actually works with immunization. Now, the precise percentage depends on how virulent the virus is. So it's actually related to its reproduction number. And of course, we have contagious variants now that are more virulent, that are more easily infect. So the percentage of the population to vaccinate now is actually going up. And it's concerning because we thought 70% of the population ought to be enough. It's probably in the 80s now. And that's going to take a lot of people's willingness, because I don't think anyone thinks it's a good idea to forcibly vaccinate people. That's not the way you win hearts and minds. That's not the way you have a happy, healthy society. You don't do that. You do it through education. And for some people who just won't have the vaccine, well, they won't have the vaccine. They're taking a little bit risk among them on themselves. They're posing a little risk to people around them. But you know what? The world is free, and ultimately, or at least it's supposed to be. And ultimately, the herd doesn't have to encompass every single individual. So that's a bit of good news, right? That people who feel that it's going to come to them being forced to be vaccinated. No. I don't see governments wanting to do that at all. I don't see the need to do it at all. But the idea of herd immunity through natural means, that is, let's just let everyone get sick, right? And there's a lot of people who say, look, COVID is nothing to most people. Let's just let everybody get sick. So of all the people who get COVID, we don't know about the number of people who really don't suffer at all, because we can't really easily measure that. But we know among the people who catch it, who we know about 20% need medical help. And of that, a significant proportion need serious medical help, right? And something like 1%, maybe 2% will die. That doesn't sound like a very large number. But if we think about Canada, that's got, say, 40 million people, 1% is 400,000. That's a lot of deaths, like 400,000 people. Mr. Ford is fond of saying 99% of people didn't get COVID today. Okay, but in Ontario, what about 145,000 people who represent that 1%? So it's easy to make this disease seem like nothing based on that tiny, tiny, tiny percentage. But my point is that if you try to get to herd immunity through natural means, you are committing to a lot of illness and death, even if that case fatality rate is very, very small. And the question is, well, is this better for the economy? Are we killing the economy? Should we just let this go through? No economy has benefited. I mean, Brazil's economy is not in good shape, right? It's not in good shape. Letting it run roughshod actually causes societal breakdown. It's not good. It's why we have a healthcare system, and we won't have a healthcare system if we decide to let it go all the way through. So the idea of Band-Aid off fast, let's let it go through the population, doesn't make sense. We don't talk about herd immunity with respect to natural infection. It's just not a concept that really entirely makes sense, because we're not controlling the immunity. We're not creating the immunity. We're not measuring the immunity. We're just essentially standing back and doing nothing. And the idea that we can achieve herd immunity, in other words, achieve what we achieve with vaccinations by letting the bug propagate through the population, it's not the same thing at all. And the main reason for that is the virus, while viruses are not technically alive, they sure are adaptable. And in that sense, they've got intelligence, right? They don't have intelligence like you and I talk about it. They don't think and feel and
Darwinian intelligence.
yeah, and they're not writing poetry, but they're adapting, right? They're adapting to their environment. So COVID's been in us, right? It's been in humans for a little bit over a year, almost a year and a half, and it's doing what it does. It adapts, and that's where these variants come from. And notice the variants, all of them, come from places where COVID is rife: the UK, South Africa, Brazil, India, the United States, the top countries for having decided that maybe herd immunity is okay. That's where these contagious variants come from. Why? Because the virus is adapting. A lot of viruses start out, if they cross into a new species, they're way too deadly. They're way, way too deadly. They kill too fast, right? The reproduction number is low because they kill too fast. Viruses don't actually benefit from killing their host. Right? That's actually very maladaptive. So viruses that start out being very deadly, they tend to attenuate. That is, they'll evolve to be less deadly because that's more successful. COVID has the opposite problem. COVID isn't quite infectious enough, right? Which is why a lot of people are saying, hey, it's kind of like the flu. So yes, it's not affecting a lot of people. It's not affecting kids very heavily. It's not affecting young, healthy people very heavily. So if you're COVID and you're looking for new markets, you've already killed off all the old people, proverbially looking for new markets. What do? Well, you try and adapt. You try and adapt so that you're more effective. So COVID has gotten more dangerous, more virulent, more contagious because it's simply just trying to look at its environment and say, I got plenty of people I want to infect, and there's a bunch I've already killed, and there's a bunch who've already recovered and gained immunity. So my buffet table's getting smaller. I need to find a way to make the buffet table bigger. I'm going to evolve. And so, people who talk about herd immunity are kind of conveniently ignoring the fact that you're actually compelling the disease, in this case, to get worse and worse and worse until it is really deadly, like the sort of thing that we don't want to see.
So I don't know what the latest numbers on vaccine hesitancy are, but there's somewhere in the realm of 25 to 40%, depending what country and what part of the country you're looking at. Canada, the US, if you're in the Bible Belt, it's going to be higher. So say we only make it to 65% immunization there, but there's already been a 10 or 15% penetration of people who've actually been infected and had antibodies. Can you add those together? Can you kind of add vaccination plus naturally occurring antibodies to get to herd immunity, at least while those antibodies last?
Sort of. And so there's two caveats. One is exactly what you just said, as long as antibodies last. We don't know because we haven't had time to know. Does the antibody immune effect of vaccination, does it wear off over time? It might. That's true for some vaccines, not true for others. The immune system's complicated. We don't understand as much of it as we wish we would. So there's some uncertainty there. But also we have to think about, well, if we're giving the virus a chance to adapt, which is what the virus wants to do, and it's able to adapt around vaccines, then you've got a problem. So the idea that you've vaccinated a chunk of people, a good chunk of people, another chunk of people have gotten it and survived, and then there's bunch of people who are susceptible. You're giving the virus an opportunity. You're saying, okay, virus, the pressure's on. Right? You've got a very small target market now. What are you going to do about it, virus? And the virus's response, if it's able, is to say, well, I'm going to develop a way to get around that vaccine. I'm going to develop a way to get around that natural immunity. And that's exactly what happened with the Brazil variant, right? So it's got a particular mutation, the E484K. Sometimes people call it the EEK mutation. That mutation has vaccine evading and immune system evading capabilities in the same way that the flu is not in the same way, it's different, but in a similar manner to the flu.
Is that the P1 variant that people are talking about?
The P variant, yeah, it is just one. However, my understanding is this variant has also surfaced in the UK. Sorry, this mutation has also surfaced in the UK variant. Mutations can happen by accident, and they can converge. So if you've got a billion people with COVID, and each of them has a billion virions in them, that's a lot of mutation, right? So it's like an infinite number of monkeys and their typewriters. If you have enough COVID, the same reproducing and mutating, the same mutation can occur by chance in two different places. And if
it's not that big a genome.
Exactly. So there's only 30,000 genes in there, right? So if you've got billions upon billions of reproductions and mutations, then that's bound to happen. I do have a piece of good news in here, though. Flu is a slippery customer. Flu mutates so fast. It mutates around vaccines within a flu season. And because so few people get the flu shot, it makes the situation even worse. And COVID ought to be a fast mutator, but it isn't. It's got a gene, a maladaptive gene, I would say, that slows down mutation. It basically works to do proofreading, and it says, "Wait a minute, let's just make sure we got this copy right before we let it go." And that is a really stupid thing to have if you're a virus. So let's hope it doesn't lose that gene. But while it's got it, it's actually a very slow mutator. And why that's good news is if we can just keep the circulation levels down. In other words, you can make up for a slow rate of mutation by having lots of monkeys at the typewriters, even if they're slow typers, right? Just add more monkeys. So if there's more virus out there, a slow rate of mutation is compensated by just more going on. So if we can actually get transmission under control globally, COVID is not going to mutate out from under us. Our ability to tweak vaccines will be much faster than COVID's ability to mutate. So, I think in all of this, we win. Eventually we win for people who get vaccinated and people who don't get vaccinated. The problem is the fewer people who get vaccinated, the longer the end game, the longer the cat and mouse or whack-a-mole or whatever metaphor you want, the more chances you give COVID. The more you say, okay, COVID, last chance. Here's some vaccinated people, here's some recovered people, and here's some fully susceptible people. See what you can do. Organisms are really good at adapting, even maladaptive, slow mutating ones, as we have seen. So it's really important to think about lower transmission rates just to slow that down, so that we can be faster with our vaccines than COVID is with its mutation.
You've been talking about Brazil, you've been talking about variants and herd immunity, and didn't epidemiologists, think that maybe the city of Manaus had reached herd immunity naturally, and then it got destroyed by a second wave?
They got to about 75% of the population, they think, and you do that by testing people's blood, right? So you go and you pick a random sample of people to volunteer, you draw their blood, you look for antibodies and go, okay, there's no vaccination program here. If you've got these antibodies, you came about them honestly. So about 75%, and that should be for classic COVID, old COVID, that should be enough. And sure enough, cases started to crash, which is great. And then, yes, they started to surge. Why? Because of the evolutionary pressure on COVID. COVID's looking around thinking, my target market, my buffet table is getting smaller, and mutations become really important. That's where the P1 came from. That's where the P1 mutation came from. That's a variant. That is where vaccine evasion and immune system evasion came from, was right there. Yeah.
Okay. Yeah, I find your message that eventually we whack the hell out of this mole hopeful, but what kind of time scale? Assuming, I guess we've got two scenarios. One is we've got widespread buy-in into vaccination, call it, I don't know, 80%. Another, we've got tons of vaccine hesitancy in the developed world. We get to, I don't know, 65% in North America, and we leave the developing world to their own devices, and it ends up producing pulses and pulses and pulses of new variants. What do you see the time scale of that? Like if we pushed really hard on vaccination and we got increased the uptake, it's impossible to tell. I mean, I'm asking you to gaze into the crystal ball and prognosticate.
I mean, it depends on a couple of things. It depends on, are we going to have travel restrictions, right? Because you're right, the virus is going to mutate in different pockets of the world, and then it's going to get on airplanes if it can. Certainly, that's how it spread from Wuhan to the entire world. Are we going to have travel restrictions? Are we going to continue to do testing for people who are traveling? Are we going to have vaccine passports? Are we going to have quarantine periods? The more we have of those, the more we can tolerate pockets of COVID without actually the world becoming engulfed all over again. So it seems to me that if we're not going to do a proper job of immunization, we may need some of those measures in place. But I have another piece of potentially good news, and I make no promises, but the scientists who worked out the way to essentially construct or create instructions to construct the spike protein, which is what the mRNA vaccines are based on, the Pfizer and Moderna. What he said was, well, I created that particular recipe, that particular spike shape, and we can make any shape we want. So the question is, can we maybe now think about a shape that is so basic to the coronavirus that it doesn't matter what mutations happen. In other words, we might be able to produce a vaccine in time, and maybe a short period of time, that will be impervious to these mutations. Because the thing about a virus is there's certain parts of it that can't mutate, right? I mean, you can mutate and end up with 6 fingers on one hand or eyes that are different color. There's a lot of mutations you can have, but you can't have a mutation that actually stops internal organs from growing, right? There's parts of you that can't mutate if you still want to be you. If you still want to be survivable. So if the vaccine can target the spike in a fundamental way that cannot be changed through mutation, then we end up with a vaccine that takes care of all flavors of coronavirus, regardless of what they do, all the way back to the common cold or one of the common cold viruses. That's possible. That's possible. That's plausible. Again, no promises, but that's entirely possible. And so that is also one way forward. So we can imagine these different scenarios, a better, more versatile vaccine, stamping out transmission worldwide, or having this hybrid of some are vaccinated, some aren't, and there's outbreaks and pockets and needing to do travel restrictions and possibly having, I hate to think annual vaccination, but possibly having repeated vaccination to deal with new variants as they pop up. Those are all possible long game scenarios.
Well, Dr. Furness, I know you've got another interview that you got to do in a few minutes here, so I want to leave you with a couple minutes to
Sure,
grab
let's do
some
that.
water and wet your whistle. But thank you so much for this today. If people want to follow your work or follow your opinions, I know you're active on Twitter.
I'm not as active as some, but yes, I'm at Furness Colin, and I try and contribute where I can. I comment in the media where I can. I think it's not so much that I have an axe to grind as I think people need. I think people have the right to develop their awareness, and I think to the extent that I can help explain things, help equip people to make sense of what's going on. That's really what I'm trying to do. I have my opinions, of course. I have my biases. Everybody does, but I think the open conversation is the way forward, and that's really what I'm trying to. That's what I'm trying to accomplish with these conversations.
Yeah. Well, you're an amazing communicator, so congratulations. Keep on
Thank
fighting
you.
the good fight, and I'll give you a virtual handshake.
All
Uh,
right. Thanks.